Thank you very much for joining us today. Welcome to our webinar, which is entitled Optimal Treatment of Angina and How We Translate the Evidence into Clinical Practice. My name is Rasha Alami, and I'm a clinical senior lecturer and an interventional cardiologist at Imperial College London. And I'm joined by my good friend and colleague, Gabriele Fragasso, who's a professor of cardiovascular medicine at San Raffaele Hospital in Milan and has a real specialist interest in heart failure and in risk prevention. So we're going to start with the first of our presentations, which I will give today, and then Professor Fragasso will follow me. We will then have around 20 minutes of question time, and you should have all received a link so that you can ask us questions. We're happy to take any questions, no matter what they are, from research to real questions about how we put things into clinical practice, and myself and Professor Fragasso will be happy to answer those questions. So let's start with the first presentation, which is entitled Evolving Management of Stable Coronary Artery Disease, How the Revascularization Trials Are Affecting Our Clinical Practice. So here are my disclosures. So first, let's think about stable coronary artery disease. What causes stable coronary artery disease? Well, we know that it's caused by atheromatous plaque within the epicardial coronary arteries, or at least this is our main approach towards stable coronary artery disease. Now, we often think about the possible consequences of atheromatous coronary artery disease, and these can come in many ways. The first is that the patient might be clinically silent with no adverse consequences, and that you find this atheromatous disease incidentally, perhaps when doing a scan for another reason. The second may be that the patient presents with a stenosis, which results in reversible myocardial ischemia during stress, and you pick it up on an imaging functional scan. A patient might present with angina. And then finally, and perhaps the worst of these presentations, is that a patient may present with acute rupture with associated thrombosis and myocardial infarction. Now, often we presume that all of these things may be possible in a patient and that they will go from one stage to the next. But in fact, what we find is that the vast majority of patients have clinically silent atheromatous disease, have no adverse consequences in their lives. A smaller proportion have a stenosis, to whom the consequences of we see on an imaging scan. A smaller proportion might present with angina, and even the smallest proportion of all will present with a myocardial infarction. And it's important to remember that as you think about the trials that I'll be presenting. So let's think about this patient again. They've presented with a stenosis, and the question should be, how should we approach them? So the first question might also lead to what outcomes we aim to improve. So I would say that predominantly the outcomes that we care about are cardiovascular death, myocardial infarction, left ventricular function, and symptoms and quality of life. So let's think about the first outcomes first, cardiovascular death and MI. What do we know in terms of the evidence? Well, we know that there are broadly two sets of treatment which are available. Optimal medical therapy, which I know Professor Fragasso will go on to talk to us about, and revascularization. In terms of optimal medical therapy, there are two broad classes. The first is risk reduction medications, those medications that prevent death or MI, and those medications are important in all patients with stable coronary artery disease. The second broad class is anti-anginal medications. These improve symptoms and quality of life, and they should only be given for patients with angina because, of course, that's all that they can aim to improve. So the take-home message in terms of risk reduction is that risk reduction medical therapy in the modern era is incredibly effective in preventing acute complications of stable coronary artery disease. And again, the second talk will really cover this. But let's think much more broadly about stable coronary artery disease and what it means. So we think a lot about epicardial disease and the impact that that has on the blood supply to the heart in terms of ischemia. But in fact, what we know about these stable patients is that very often the reduction to blood supply to the heart can come from many causes. It can come from functional mechanisms such as microvascular spasm or abnormalities in vasodilatation. It can come from structural mechanisms such as issues with the coronary artery anatomy. And it can obviously come from myocardial factors that affect microvascular functions, such as left ventricular hypertrophy. And so beyond that epicardial disease that you see on an angiogram, there may be lots of different components that contribute to a reduction in blood supply to the heart. And the reason I bring this up today is because that's important to remember as we look at the evidence base. One of the major issues that we've had with ischemia and reduction to blood supply to the heart is we make many assumptions. We assume that it is linearly associated with angina, and that the worse the blood supply to your heart, the more likely it is that you have chest pain. We also assume that it is linearly associated with poor outcomes. And again, the more ischemia you have, the more the more impact it may have on cardiovascular death or myocardial infarction. We also assume that ischemia can be improved by revascularization. But remember, all that revascularization can do is improve the ischemia that's caused by an epicardial stenosis. We also assume that there's a binary cut point can be used, and that patients can have a red or a green ischemic threshold, and that we either decide to treat or not treat them based on that threshold. And finally, when improved by revascularization, we assume that when you improve ischemia, the outcomes will improve. So what treatments are available? Well, as we've said, optimal medical therapy or revascularization. But let's think about what revascularization might aim to do. So, of course, broadly in terms of revascularization, we have CABG and PCI. And I'm going to look at the evidence on whether this really can hope to improve outcomes in patients with stable coronary artery disease. So let's look at CABG first. So the studies on CABG in terms of thinking about whether CABG decreases risk in stable coronary artery disease are really very, very outdated. Many of them showed that CABG did improve mortality and myocardial infarction rates. However, the main studies were recruited for in the 1970s and 80s, when we didn't have widespread aspirin use or statin use, and there was no other disease-modifying therapies. So, of course, they're very, very different to the practice that we have now. Importantly, there did seem to be subsets of patients for whom CABG made a difference. Those were those patients with left main disease and with three vessel disease. But please remember that those trials are really quite outdated now. So while we know that CABG seems to improve mortality, it's really in an era that's quite outdated, and those trials really need to be repeated. So now let's think about angioplasty, which is really where my clinical research has been. So angioplasty has really been based on, and the study of angioplasty in stable coronary artery disease has been based on one major assumption. And that is that ischemia is associated with worse outcomes, and that if you improve ischemia, you can make patients do better. Now, one of the major issues with this assumption is that the observational data that told us that ischemia was associated with worse outcomes, it was really quite confounded. What they did was take patients with ischemia and look at their outcomes in the long term. And what we know is that patients with ischemia often have lots of comorbidities. They're often older. They often have disease that's very hard to revascularize. And it is this that maybe has impacted their outcomes. So when we then ask the question, does ischemia-driven angioplasty reduce risk in patients with stable coronary artery disease, we find some interesting results. The COURAGE data showed that actually, if we compare the angioplasty group to the medical therapy group, we find no difference in terms of long-term clinical outcomes. The ischemia data more recently showed us in those patients with moderate or severe ischemia, once again, an invasive strategy with revascularization, either with angioplasty or CABG, did not improve outcomes compared to medical therapy. And you might ask why this is. Well, it might be because ischemia is not just caused by an epicardial stenosis, and it might be because ischemia and its impact on long-term outcomes is due to many more things than just an epicardial disease that we may be able to improve with revascularization. Importantly, from the ischemia trial itself, what we've seen is that the association between ischemia and outcomes is not like we saw it in the observational data sets. In fact, more ischemia does not seem to be associated with worse outcomes in this randomized controlled trial. And maybe that's because this cohort of patients didn't have that level of comorbidity that we see in those observational studies. So what's our take-home message here? Well, actually, that ischemia-driven revascularization has not been effective in reducing death or MI in stable coronary artery disease compared to medical therapy alone. There are still some unanswered questions. It seems that the role of revascularization with CABG is still up for debate because actually, as I've said, those trials were quite outdated and we really need to assess this in a modern era. So let's look at the other outcomes that we might aim to improve. The next one is LV function. And the data from this really comes within this last year. We have seen the first trial of patients with ischemic cardiomyopathy comparing angioplasty to medical therapy alone. And what they found in the REVIVE data set was no difference in all-cause death, hospitalization for heart failure in these patients. And again, this was a little bit of a shock. Now, that might be because actually our medical therapy for patients for heart failure has significantly improved over the last decade. And perhaps there's very little more to gain from revascularizing these patients. So our take-home message here is that in patients with heart failure and coronary artery disease, revascularization with PCI did not reduce the risk of death or heart failure or hospitalization from heart failure compared to medical therapy alone. So now let's think of our next major outcome, which is symptoms and quality of life. And here we can again think about our treatment options. We know that we have anti-anginal therapies and that these improve symptoms and quality of life for those patients with angina. We'd like very much to propose that in terms of our anti-anginal therapy, we really offer a modern approach these days. And rather than a kind of stepwise approach from beta blockers and calcium channel antagonists to the next agents, then when choosing your anti-anginal agent, you think about the pathophysiology that might be causing the pain, and you tailor your medical therapy based on that. And actually that we really should aim for a very, very systematic approach to medical therapy. So if your patient might come in with stable angina, you'll give them lifestyle advice and perhaps short-acting nitrates and definitely risk prevention. They then come in for anti-anginal therapy initiation, and then you gradually, over a period of 3 to 6 months, have multiple stops at which you see them and up-titrate or introduce new anti-anginal agents before finally considering revascularization. So our take-home message for medical therapy would be that there are multiple drug classes, that they're all relatively effective in reducing symptoms and improving quality of life, but that patient-specific factors will influence which one you give them. Now, there are some issues with anti-anginal therapy. It can take time and effort. It has possible side effects. It may not work. And of course, there are issues with adherence and persistence. Of course, there are some patients who prefer not to take tablets and would prefer to have angioplasty or revascularization with CABG. And there is some issues in terms of reimbursement, which I hope does not impact on what we do. But we know that across the world, there are some areas where this really does drive differences in practice. But of course, what's important to remember is that there are patients who'll just say, I don't want to take tablets, I want you to open up the blockage. So let's look at revascularization. And what does that mean in terms of symptoms and quality of life? Well, we have lots of unblinded data that showed us that angioplasty was very effective in improving symptoms. But importantly, these were unblinded trials. And both the patients and the physicians knew exactly what they'd had done. You saw that data from the ACME trial. There was also similar data from COURAGE, showing improvement in symptoms over time, but that improvement actually attenuated as the years went on. And that may have been because there was a placebo component to angioplasty, and it may, of course, have been because some patients crossed over from the medical therapy arm to the angioplasty arm. Now, what's also important to remember is that while angioplasty might be effective in treating stable angina, our trial design can really affect this. And when you tell a patient that you've done a therapy that you believe to be effective, they often feel a lot better. And we definitely saw this from ACME, from COURAGE, and also from FAME2. So my group were the first group to perform a blinded trial in this subject. And we performed the Orbiter trial, in which we randomized patients with angina and single vessel coronary artery disease to either having an angioplasty procedure or having a placebo procedure. And those patients were followed up for 6 weeks, at which stage they had no idea what they'd had done. Our primary endpoint was a difference in exercise time between the two groups, and we found no statistically significant difference in the first blinded trial of its type. We did find that there was a small proportion of patients who said that they were angina-free after blinded successful angioplasty, but that proportion was very small, around 20% of patients. We also interestingly found that if the burden of ischemia on stress echo was high, you're more likely to have angina improvement with angioplasty. So there did seem to be a subset of patients who got better with angioplasty, but maybe it wasn't quite as big as we expected. Importantly, what we also showed was that medical therapy and anti-anginal uptitration was really very possible. We were able to get patients onto at least 3 anti-anginals within a 6-week period. So that scheme that I proposed, where you gradually increase anti-anginal therapy, is very possible. And indeed, we showed it in the Orbiter trial. So my take-home message in terms of symptoms and quality of life is that the angina relief offered by angioplasty in unblinded trials was not really replicated to the same extent in the blinded trials. So it does suggest that there's a significant placebo effect to our procedure. And that maybe what we need to remember is for patients on optimal anti-anginal therapy, the benefit of angioplasty is probably smaller than what we previously thought. So what about the clinical guidance now? Well, I think there's a place where we need to start to reconsider things. I'm not sure that we have the evidence that we used to have in terms of revascularization for proximal LAD disease, for large areas of ischemia, for hemodynamically significant stenosis, or indeed in those patients with impaired LV. And all of that is making me think that stable coronary artery disease space really needs us to consider medical therapy to be our most important first choice. Now, quickly, I want to just give you an overview of some of the future trials you can expect in this space. There are some unanswered questions. Firstly, we want to see if revascularization may offer mortality and MI benefit over the long term, because of course we've only got medium-term data from many of our trials. And so this will come to us from Ischemia Extend, where the results of ischemia and the follow-up of ischemia will be followed up to 10 years. And the primary endpoint will be death from cardiovascular causes. So we can really see if patients, perhaps in their 40s or 50s, should really have a conservative approach, or whether these patients should be considered for revascularization. The next major unanswered question is, are there subsets of patients with ischemic cardiomyopathy from that REVIVE trial who might benefit from revascularization with PCI? And so we saw that REVIVE data, but the questions now will be from the CMR data set. Is it possible that those patients with more ischemia, or those patients who have hibernating myocardium, might be more likely to get benefit from revascularization? They will also give us data from the core lab and the angiography core lab, where they will tell us if completeness of revascularization or chronic total occlusions had an impact on the results. The next answer question is, we saw from Orbiter the placebo-controlled effect of angioplasty in a cohort of patients who had a lot of medical therapy. And the question now will be, in those patients who don't tolerate that level of medical therapy, what effect can you expect from angioplasty? And can you maybe offer patients a choice of strategy? Some patients may want more medication, some patients want less. What can we do in terms of offering them different approaches? So we're taking patients who have angina, they have evidence of ischemia, and they have severe coronary artery disease, either single or multi-vessel disease this time. There are a number of differences between the trials, but the major difference is that in Orbiter 2, there is far less medical therapy. There is minimally tolerated medical therapy. The duration is much longer at 12 weeks, but also importantly, it remains a placebo-controlled trial. So we are still randomizing patients to angioplasty versus placebo. We'll hope that the results from that trial will be available this year. The next of the unanswered questions is there a better way to select patients for revascularization? And can we identify which symptoms will respond to PCI? We're going to be presenting data in the next few months from the Orbiter STAR trial, where we're really asking the question about chest pain. And our major study is it possible that the chest pain that some patients have is not from their epicardial stenosis, but from other causes? And perhaps for those patients, maybe angioplasty doesn't work quite as well. So it's based on that premise that we often have in the cath lab, where if we open up a stenosis and the patient reports pain, we say to them, is that your angina? And if they say yes, we're relieved. We think, well, that's good. Maybe I will have made a difference. If, however, they say, I've never experienced that sensation before, we're totally disheartened and we're worried that maybe what we're doing won't make a difference to their symptoms. And so the Orbiter STAR trial is a placebo-controlled in-cath lab experiment where we're going to present the data for symptom similarity from blowing up a balloon versus placebo inflations, and we'll see if that makes a difference in terms of their long-term symptom improvement with angioplasty. The next major question that we're going to be trying to answer in the next few years is, can we find physiological thresholds for angina? Because we believe that that's never really been defined, and we'll be doing that from the Orbiter FIRE trial. And then finally, we're asking the question, are the treatment options that we have are enough? And is it possible that there are other treatment strategies? And here we're going to be testing a relatively new device, the coronary sinus reducer, and looking at the mechanistic effect of this device in patients with refractory angina. And here in the Orbiter Cosmic trial, we're randomizing patients to either have the reducer or placebo and looking at the long-term effect in terms of their symptoms in a blinded trial, but also looking at the effect on myocardial perfusion on MRI. So in summary, I believe that one size doesn't fit all, and that we haven't found the answer in terms of revascularization for all of our patients. I believe that we can take our time and that we have very good medical therapy that gives us that time. I also think that it's important to consider a trial of anti-anginal therapy because it allows you to evaluate patients' symptoms and also consider revascularization for those who are most likely to benefit. Importantly, revascularization always remains an option in your patients, and you can bring them back for this in time. I think it's also important to remember shared decision-making in these patients, because our patients need to be involved in making a decision on what they want next, and that should hopefully improve their long-term outcomes. And finally, of course, we always have a lot to learn. So I will stop there